Welcome back to Something Else Today podcast. I am your host, DJ Matlala. And a few months ago, we got some backlash when we were talking about the medical industry without professional opinion. And now we are back trying to correct that. And we are going to talk everything medical industry, palliative care. We are joined by a private nurse, Khululwa Mboqoka, who's going to tell us everything that we need to know. Hi, Sisi, welcome. How are you doing?
Thank you for having me today. I am Khululwa Mboqoka. I will be talking to you regarding healthcare today.
Thank you so much. I see you even came professionally dressed.
Yes, I don't want to be Sister where Soul City.
Oh.
You remember Sister Bettina in Soul City?
Oh.
Yes, that's how professional we are, As professionals in healthcare, we are always identified. And it is a basic right, it's patients' rights that we are identified, we wear our distinguishing devices because this tells you what category is treating you at a time. So it's very important that when you interact with a healthcare professional, they are well identified. So this is how I am identified. In any case, I have my name here, so I would have put on my name tag, but we are not treating anyone, we are having an interview.
Yes, 100%. So Sister Mboqoka here was telling us about her voice, that it's actually natural, guys. So please, she does not have a flu. It's an amazing voice. I was telling her to do radio ads because we try to hear our voices and it doesn't work. So
natural hair.
Asham, you have an amazing voice. I would be milking radio stations by now.
Really? Oh, maybe I'll try.
Yeah, medical talks on radio,
Okay.
Maybe you become a resident medical talk here said podcast. You never know.
Maybe, yes. Maybe we can do that actually. It would be nice.
So tell us a bit more about yourself.
I am Khululwa. I'm just a lady. I'm no longer a girl. You saw my daughter is so big, so I can't call myself I'm just a girl. I'm a lady from Matatiele. It's a small town in the Eastern Cape. Kwamakhoba. In the rural areas, there are villages. Yeah, so I come from a village called Mandastone. The area is Makhoba, which is our chief. So our chieftaincy is under Makhoba. That is where I come from. I studied there. My primary school was Makhoba Junior, and I went to Mnugwa, and both these schools are named under our chiefs. Then from there, I started my nursing career. I started nursing more than 20 years now, eh? I don't look like it, but yeah. So over a decade, imagine. That's why I'm tired, guys. Really tired of it. But yeah, my career started as a home care nurse, which is interesting because after your invitation, I thought about it and I'm like, I have actually gone back to where I started because I started as a carer in 2003, 2004. And then I'd never understood what was the business about, honestly. But I knew I was allocated to go look after a specific gogo or a specific mkulu in their homes. And I would look after them. And I used to do night shift because at that time I was studying, progressing my studies in nursing. So yeah, that's where I started. I've been advancing. At this level, I hold a master's degree in nursing management. I have a postgrad in business management from Nkosa. I have numerous courses that I have attended that are related to our field. Mm-hmm. So, yeah.
So, guys, she's more than qualified to be on the podcast. More than. Amazing.
The years of experience, I've got 10 years of experience in the nursing management space. That doesn't include the general roles that I have held. So, just in management alone. I started as a unit manager, which progresses you to the role of a matron. And over the years, I think most of the people were very surprised to find me in the boardrooms because I'm more in private healthcare, which we also collaborate with government at times. But my big chunk of work experience is in private healthcare. So they were like, why a matron? Mabeti bizano matron. And then I walk in, but matron law. Because they expected Abokoko, you know Mosabo Metron, how they walk. Yes, it's that olden version. It doesn't happen anymore, guys, at home. Now the matrons look like this.
So a matron is like someone who takes care of.
A matron is a senior nurse in the hospital, just to put it in a simple terms.
Oh,
it's the senior nurse in the hospital who takes charge and coordinates the nursing services. So everything in hospital that relates to nursing care, the regulations, the compliance, who does what. If the nurse matron doesn't approve of it, it's not going to happen. If it happens, you're on the red carpet. That's my role.
So you were doing this in private care?
Yes.
And how was it?
I learned a lot. It was very challenging. One, we know that in our culture, it's not a secret that there are racial issues. So because I was in the private healthcare space, it's very difficult to deal with specific doctors, specific cultural groups, because sometimes you're expected to interact with someone who says, can I speak with someone who only speaks Afrikaans? And you're like, but I'm only the sister in church today, so we're going to try English, ma'am. So those kind of challenges. But other than work-related situations, no problems at all, because it's things that I have gone through as the career progresses. So managing the hospital, I have acted as a hospital manager. I have managed programs to roll out educational. I have designed programs for education. It's not really a thing that you would think, oh, it's frightening. Get in and do it. And as you do it, you learn, allow, and be teachable. Then you will be able to navigate. I've had my role models, my mentors, because that is also important. When you are coming in as a nurse, you are moving and career progressing. Your role changes from clinical operations to administrative. And when you get to the administrative roles, then you can see, this is now another world, which is why I have been studying. Each time I get to a specific role, I identify a gap. Let me make an example. Business studies. I had to do business studies beside the fact that I had a vision of a business of my own, which I was running, and I knew that my biggest thing was just accounting and financial management. But when I got to the business program, I learned operations management. I was in one assignment, I was very annoyed because I had to open up a McDonald's. What the hell? What am I going to do with a McDonald's? I'm a nurse, So, but because you advance and you learn these skills, then you understand in that meeting, in that boardroom, this is what we meant when we were looking at the balance sheet. This is what we meant when we said we didn't reach our financial KPIs. So it is very important to get educated, align what you are studying with what you are doing and what you are aiming for. I don't know if I can refer to your first speaker who said a theory is very important, but practical experience gives you the actual knowledge. In my study, when I was doing my master's degree, that was actually the problem, because I was saying the integration of theory into practice is lacking. Yeah, so that's management role.
Wow.
That was a mouthful, eh?
That was a mouthful, actually.
For a nurse. You thought I was saying
like
injection. And yeah.
Left or right, sis?
Yeah, next.
Next. Abuti, batla inge? So why did you stop taking your medication? You know, the public side. So I think you were like on the private side, because the public side is which we're going to get into later on. So I'm very, very curious about what is palliative care, because you say this is one of the things that you specialize in your private practice.
Yes. Palliative care is a service that is there for advanced illnesses. So most of the people are diagnosed, let's just say, with cancer is the most popular one that gets into palliative. But actually your chronic respiratory disease get you into a palliative program, because it's an advanced illness that you live with for a long term and you need support to get through for symptom management, coping mechanism, whatever it is that you're struggling with. So cancer patients mostly struggle with pain management, your symptoms on chemotherapy, where they get your nausea, diarrhea, and the likes, and they are really, really struggling because chemo can take a lot from you. However, let's just take another example on a respiratory disease, which is chronic obstructive airway disease, COPD. where patients cannot live without oxygen. They are totally dependent on oxygen. And that attacks mostly your smokers, your people that are working in the mines, the lungs are affected, and they are not now functioning according to their optimum anatomically and physiology of their natural bodies. So those advanced illnesses get you into a benefit where medical aid says your disease is not curable, but you are still going to get treatment. Therefore, you are able to be supported at home. You are able to be supported wherever you are. You don't need to be admitted all the time. That is where we come in.
Yes. I don't smoke, so... does it affect people who also don't smoke, these diseases? How common?
The respiratory disease that we saw that affects everyone was COVID, because during COVID time, we were just passing by, then suddenly I'm coughing, right? Exactly. And we never understood what was going on there as a general public. But most of the people that get respiratory disease are the smokers or your congenital disease, like your asthmas that just start, because sometimes people get asthmatic at their very young age, others get asthmatic as they grow. So there are different diagnostic levels to all these diseases. It's not just a one-size-fits-all.
That's very, very interesting because, there's an article I attached here that says the need for palliative care in South Africa is evident from the Statistics South Africa 2018 report, where 59% of deaths in South Africa were from non-communicable diseases, e.g., cancer, diabetes, and heart diseases. And 25% were from communicable diseases, which is human immunodeficiency virus, which is HIV, tuberculosis, and 12% was from injuries. So, one of the things that they actually spoke about is that one of the very interesting things that they spoke about on that article was assisted death. So, do you think the South African law should allow for assisted death?
We are a very diverse country in terms of our cultural beliefs. And if I, for one, as a professional, I know the law says it's illegal now. However, what do we mean by assisted death? Because right now, people believe that palliative care is assisted death, because the belief out there is that you are only referred to palliation when it's near end of life. But actually, that is not the case. If doctors that are treating in the acute facilities are open to this support system, because palliative care is providing support to the families, assisting others to die, the public believes that it's morphine injection, shoop, we give you and off you go to your maker. I don't know what people want to see happen, I don't know what they would prefer to use to be assisted to die, but dying is a natural process. So if I am, as a medical practitioner, saying I am helping you to die, it is illegal to kill. I would have killed someone. But if it's regulated under our healthcare sector in a specific way, obviously it would go according to how it should be done. Most of the public communities, even myself, there are drugs that are associated with, if you use this drug, you are going to, like, people commit suicide every day. That's assisted death. But it's just that I assisted myself in this case, because I could not deal with what I had to deal with, or my psychological space is not in the right space. It's the space in the right space. It's just that. But legalizing it, I can assure you, I have nothing against it, as long as the people who believe they need assistance. We are African, Tribandu. We really are.
Which the reason why I'm also asking is because on the article I read, Jorge, one of the things that I read about was that, no worries, that sometimes you see someone who's in pain and they're not dying and they become in pain for years or for months, and you can tell that they would rather die than deal with so much pain, regardless of how much morphine or drugs that they prescribed. It still does not help their pain. So hence the whole situation of the assisted death, because you can't measure how much pain someone feels in any medical field. Like, we can't put you on a, what's that machine that measures your contractions, where they put it and then it does the whole
contractions.
you're in pain and then you're stopping and they come. We can't do that with like pain from cancer or pain from I don't know, HIV, when you've reached AIDS. Like, we can't necessarily do that.
We do have measures.
There is.
We do have a measure of pain scale. For kids, we use faces. I'm not going to get into the deep terminology. Okay. For adults, we use a pain scale, and we also use those scales for triage system in the emergency department. So if you come into an emergency center and you say, I've got abdominal pain, or you say, I've got pec pain, we are going to ask you, out of a scale of 10, how much would you rate your pain? And then we will tell you 0 to this much, it's this pain. And we use faces for kids because it shows you, here I'm crying, here, you know. So those are the things that we use. But let's talk more about the cancer patients and the pain management around cancer patients. Pain management around cancer patients is divided into two. We have got drugs that we use according to stages of your pain management. And also, patients can feel pain, but it's not physical pain. It's psychologically associated, because I am supposed to be feeling pain, but because of the medication that I've been given, I am no longer feeling the pain, but I know I should be feeling pain. So I will keep complaining about pain. And that is where psychological support comes in, so that we manage your pain without now adding more medication, but we are now calling social workers, we're calling psychologists, we give you counseling, and then 3 days later, I'm much better. You see, so it's a dimension, or it's a sequence of events that may lead to how do we treat you? That is why in my services I have separated pain management, and it's a service on its own, so that people know that you don't have to suffer. You can book a consultation, we work around your medication, and that is why people are non-compliant, and they have a polypharm. We call it a polypharmacy, because they come to the hospital with a basket full of meds, but they are still in pain. When I look here, there's every drug possible. The problem is, how do I use these drugs? Doctor has written a script for me. I'm going home. And doctor says, Panado syrup 6 hourly, Oxynom 6 hourly. So everything is every 6 hours. So as a normal person at home, I wake up and I have my breakfast at 8. I take Alice at 8. Come 10 o'clock, I'm starting to feel nice and high. I'm going to sleep. I wake up at 12, because also their sleeping patterns are disrupted. I wake up at 10, medication is now not working because I'm awake. By the time I was nice and high, I was not feeling anything. I slept. But because now I'm up, I'm thinking, but by the way, I slept because I had pain. And then I come back, I think that I should be in pain. Then you start crying. Patients like that do not cope. When they are at home, they want to go to the hospital. When they are in the hospital, they want to go home. Yes, because we need that planning, that assistance. And this service I'm offering, it doesn't need to be prescribed most of the time. The advanced illness benefit with other medical aids, such as the blue one in Sandton, they are benefits. The problem is that we don't know the baskets that we have in our medical aid. And on top of it, we wait for the doctor to refer. We don't talk about these things because we are not knowledgeable. So as soon as I am aware that, but by the way, I can get support, you can consult medical aid covers, you can consult private clients are covered for, the services available at your disposal, but we are not aware.
There's a lot going on in this industry. Yeah. So now, how do you actually integrate, the cultural and cultural support, spiritual and cultural support, and palliative care?
Palliative care happens a lot at home, but let's just take it to the hospital space. We are a diverse nation, a very diverse nation. Helping a Zulu man, I'll make an example because I'm a mixed breed. I am Zulu and I'm Xhosa, So I am now coming here. my understanding is that when I speak to a man, I maintain a distance. I don't look at him in the eye, and. But now I'm coming to attend to another race, not even Umpedi, not even Umsutu, but the other race. The other race interprets my body language differently. They are seeing me as being dismissive as compared to me trying to be respectful. Because in my culture, I'm not looking at a man like this. I'm talking to a man like this. But with the other races, you talk to me, you are direct, you are. So those are the things that we need to teach our nurses. We need to make them understand the cultural dynamics. But I have learned these things as I grew in the profession as well. That when you talk to me and you're saying, Okupametsi, as a patient, I don't need to talk to you when I'm standing far away or further at a distance and I'm looking that direction. You see, so those are the things that patients perceive as disrespectful, not so compassionate, unempathetic. So sympathy, empathy, compassion are interpreted exactly in that cultural diverse space.
Yeah.
I talk a lot now.
No. It's amazing. we love the information. I'm taking in the information, because every time you also see when you walk into a clinic and a nurse is shouting, it's just not, it doesn't look like they're being sympathetic at all or empathetic or they're showing any form of compassion at all. Because warasa, next, it's like 8 o'clock in the morning, so it's very, and as if you're at a retail shop, it's just kind of, maybe that's why people are now opting, for opting for medical aid, because you can complain and you can say, I'm not going to come back here and all of that. But if you're in public care, you can't necessarily. It's the clinic that is closest to your address and where your file is at. And your file has been there since you were a child in most cases. So, and then we move on to this that says hundreds of people, many of them frail and elderly, have been standing in queues in cold, wet conditions to prove that they're entitled to receive their SASSA grants. So due to the elderly not being strong enough, they normally send family members to collect their grants. Would you say this is one of the reasons why family members opt to take care of their elderlies instead of, when they're not really fully trained, instead of bringing in a professional?
Yes, that contributes, as well as the fact that we are sitting with a high unemployment rate. So there are no means in any way that the communities or the families would be able to afford a service where they can hire someone. And in most, because I offer the service of home-based care and offer you a carer, most of the people are not able to differentiate between providing a carer, which is home-based nursing, and a domestic. And that is where it becomes a problem, because they expect you to be a carer and a nurse, but you also be doing the duties of a domestic at a lower rate. So the issue here is that somewhere along the line, we had people that were called home-based from government, who would go and do, I can't remember whether they were under social services or they were coming from the healthcare system. But the healthcare system ones were in the clinics where they go and check your medication as a gogo in the house. And the social services ones, I think they were there to check. We were growing up in our village. They were coming to check, is a social worker. They were coming to check the social status in the home. Is she getting the support? Is she being bathed? Is she eating? Is she taking her meds? And there was that collaboration between the health system and the health sector and the social services department. At this stage, I don't know what's the status quo in terms of those services being available. However, in answering, do I think the people opt for caring because they can't afford? Of course. But then that puts a burden in the employment rate as well, because your absenteeism at work impacts you getting employed or not getting employed. You are going to be chased away at work. You will be fired because of your absenteeism rate. Yes, and it is unfortunate. Ngapha uyagulelwa, and you think umphathi wakho or your boss is not compassionate or akakuzweli, because all he wants is your deadlines, and when now you cannot cope with the deadlines, because when you get home, you become a nurse that you are not trained. And you then have we call it care fatigue, primary care giver fatigue, because now you are taking on responsibilities that are not yours, that you're not trained for. You are irritable. As nurses, we deal with not so nice things. And when people are sick, they are going to do those things. The not so nice things are natural.
Or not so nice things?
The not so nice things, your bed bathing, your bathroom visits that just happen, because now Koko cannot go, or mama Koko munye une dementia, or agasakhona ukukhumbula, agasakhona ukuzizwa, can't remember. And actually when you put them on the chair, they think they are in the right place. Somewhere they do the deed there. So as someone who's not trained, you get like, what's cooking now here? How do I handle this? And you get frustrated. In that frustration, your psychological stress, you are absent at work, things are piling up, you lose your job, Koko dies, then we say you lose you. Yes, you see, izinto zakhe zimnyama manje, they are all dark, because why? Alahlekelwa umsebenzi kwashona ugogo, alahlekelwa umsebenzi. No, it's because your work record, your attendance record at work was affected by these circumstances.
So do you think also these fraud activities where you find that, caregivers are actually collecting SASSA on behalf of someone and they die and they still continue to collect the SASSA because they don't report to death because of it helps them due to the high unemployment rates? What do you think of that?
Yes and no. Look, you can't taint your integrity and your ethics just because you want to save yourself. You're putting yourself more in trouble, because when you are caught, and you are not, nobody's going to hear your sob story. By the way, we didn't put a disclaimer when we started.
No, there is a disclaimer. We always...
The views are not from SANC. They are not from the Nursing Council. They are from me. They are not... Nursing Council is my regulatory board.
Okay.
As a registered nurse, I have a scope of practice. All these views are not guided by Nursing Council and the National Department of Health. It is my professional experience.
Okay, 100%. We normally have a disclaimer that says, not necessarily that specific. That's very specific.
Yeah. So we would just right away in the middle of the process are like... now they
we
go
always
and
have
say,
a disclaimer though.
That is why you see, with this disclaimer, I'm remembering because I am wearing my epaulets here.
Okay.
So whoever doesn't feel like this information I'm sharing can now come and say, yeah, but nurses said on TV. I'm not talking for nurses, I'm talking for myself.
100%. So what we're going to do for that is that please do write us like a thing so that every time we clip your TikToks, we put it at the end so that it's there, so that everybody knows. If someone says whatever, they've missed the disclaimer, so that everybody is on the good legal side of TikTok and Instagram and YouTube Shorts. Okay. So now we move on to the ones that we're all curious about: nursing and customer service in public hospitals and clinics. I'm going to read something here, but God. There has been a rise in patient harm in Gauteng public hospitals. This is due to the amount of factors that frustrate the hospital staff and makes it hard for them to perform their jobs, hence leaving room for errors that can be referred to as hospital negligence. The death toll The death toll has also risen throughout the year. These are the following incidents. Please see. So at the top three, we have Chris Hani with 1,257 cases. We have George Mukari Hospital with 600 cases. And we also have number 3, Steve Biko Hospital with 592 cases. And I'm just going to mention a bonus one, Cat Matlala at 498 cases of hospital negligence. So let's talk about that.
Hospital negligence or healthcare negligence. Again, this is not justification. Ne?
Okay.
Unfortunately, it's things that are going to happen. And I'll make an example for the public to understand what do I mean.
Okay.
Healthcare risk is there. If you go to an operation, you are given a consent. And this is an example. You're given a consent, and the doctor needs to explain to you what possible complications. So that already tells you that there is a chance. But we trust our doctors, we trust our nurses, we trust everyone in the facility that they are skills, of course, because they are trained. However, with lack of accountability and administration, we have seen our communities not trusting the public service, and it's there. Why is it there? It's because there is no visible administration. The people that are supposed to be holding each other accountable are not. The simple thing, like laying a complaint, process is there. But have you ever heard someone saying, I have laid a complaint with Baragwanath and I have actually been attended, thank you very much. No, it was a trend on social media and it ends there. There is no accountability, and the public has resorted now to use TikTok jail or Facebook jail, where if they saw your face and they got a moment, they are going to thrash you on social media because the voices are not heard in terms of making sure that the policies that are guiding practice, because there are policies there, the policies that are working, just for your information, the policies that we are using in the private sector are the same policies that the government wrote. We didn't make our own in the private sector. We are regulated by the same people. We are accounting to the same occupational healthcare standard, OHSC. They audit everyone. We are audited as private healthcare by DOH. So tell me, if they come to my facility and they penalize me for not having an intubation item on the emergency trolley, do they have it in theirs? Otherwise, the facilities wouldn't be looking like that, would they?
No.
Exactly. So it's lack of accountability and responsibility. Policies are there, they are the same. In private healthcare, how many times have you had somebody going for an eye operation and die? It does happen, but it's rare. Because if you go for an operation, there must be work, and I'm just using operations because those are the most negligent or rather healthcare legal matters that arise that would cause major events or catastrophic events in our terminology. A near miss is something that we catch. A near miss is something like you are misidentified and you were about to go to theater and another nurse saw, but you are written Mrs. Mboqoka for a hysterectomy instead of Mrs. Mboqoka for a G-scope. So those are the things that we catch them before they happen. But how do we get onto a table with a patient that is a high risk, which we know that the moment we put anesthetic, that patient stands a chance to die? How do we get into a theater, we amputate your right instead of your left, and nothing happens? So these things happen, whether you are in private or you're but the problem is, the difference is the accountability. You will never get to do that in private sector and still see the day. Cat, fast.
You mean you'll never...
You will join Matlala in the orange suit. Because there's accountability. We run like headless chicken if there's an incident. Even if you Amber fell, why did you nearly fall in the first place? Aulandanga on the floor. You nearly landed. But for that alone. So it's the same principles. But unfortunately, the other space doesn't take accountability serious.
Wow. That is very informative. I didn't know all of this. And also, I have a question, and we are so sorry, but we have to ask, why are nurses so rude to patients in public care?
Can I please correct your English?
Okay, yes, please.
I'm not intending to correct your English, but I am trying to answer appropriately. If we say why nurses are rude, I'm going to say because, and then it justifies the whole thing.
Okay.
Ne? What contributes to the nurses' negative attitudes? Okay? I don't want to say because we are, because then I'm making it sound like it's right. As public servants, it doesn't matter where you are. You are there to render a service. And I think that is what we need as a healthcare sector to look at now. We need to really understand and take it upon ourselves that we are service providers, which means then we are there to serve. And it's not the other way around, because currently it seems like we are doing people a favor. So where else should they go?
Yes.
Nurses will complain about the resource allocation, about this happened, about that happened. You have no reason to be rude. It doesn't matter where I meet you. Even if I am at the till at ShopRite, we have 3 categories of the most rudest people in the country. Taxi driver, hotel was a ShopRite, no nurse. Ane? In the country. That is just known. But if you go to the taxi rank, by the time uhamba bazobe bekthukile. If you go to ShopRite, by the time uhamba bazobe beshube plastic or something. No nurse. I think as nurses, we need to start taking accountability and take pride in our profession. And next year, I'm going to be running a campaign. There's another part of me that does professional development. So when I do professional development, I am looking at exactly, and I'm taking it upon myself to teach customer service, and it's open to everyone. Because we don't have a course for customer service. However, patient experience is a KPI, key performance indicator, in private healthcare. Dare you me go to private healthcare now at reception and somebody talks to you not looking at you? Kungeni email engaka. And we must jump up and down. By the time you get to the ward, you are already irritable. It was never my problem as a nursing services manager. At that point, it happened. It happened at reception. But by the time you get there, you are irritated. You are telling a man, so now you are going to complain about nursing care and about was a reception. And I need to come to you and apologize. I need to come and address my people. Guys, why did you treat Mrs. So this way? What happened? And it's a serious issue. It's a hoo-ha. You are going to get to the matron's office and answer for yourself. So unfortunately, it doesn't happen that way on the other side of the network.
But the other side, when it happens, it's okay. It just passes.
The reason it feels like that, it feels like it just passes. Maybe they are addressed. But they are addressed and then it ends there. Nobody comes back to the public, because have you ever heard anyone coming back about that child, that baby in Eddington Hospital? All we heard was that mama delivered on the street, and it trended and we were told, no, they are investigating, and nobody came and addressed. And that, I think that is the issue. We don't come back and address issues for the public to understand with, okay, yes, we believe this happened, but no, hang on, this was not the right story, because it does happen that things are blown out of proportion. But hang on, guys, this was not what actually transpired. But then explain to us, how did we see that on video? You will come, of course, with, because when there's an incident, there's a root cause analysis, there's an investigation process, there's a root cause analysis process, and then you get to find the actual things that happened, and then you are able to report back and say, okay, this is what actually transpired. So why is the government taking that part so lightly? Why is the public sector not coming back? How do kids get switched in the hospital? We hear it about it on the radio. We don't hear about the verdict. And I think that is what we are lacking. And as we get to the NHI, I will tell you why do we need to address this.
Wow. So now, maybe let's also come back to how to, what factors in the public environment make it harder for these nurses in the public space to actually deliver good customer service. I mean, we see the understaffing, the long queues, and the resource shortages. So please, according to your experience and what you've observed, and also what you've heard or what you guys have talked about in your circles? Because I'm assuming that maybe some of the people you went to school with are maybe in public and you are in private. So can you tell us about that?
It's all those that you have counted. Those are the contributory factors. That is why I said to you, I don't want to answer why, because then it's going to be justifiable. The contributory factors are the limited resources that are available at nurses' disposal. I'll make an example. In 2009, I was not yet a fully fledged nurse. I had just completed my studies as an enrolled nurse, and I was pregnant, and I had a placenta abruptio. And how this happened was I was in hospital as a preterm labor, so I felt like I was going to deliver, and then I was taken to hospital. I stayed there for a week. On that particular Friday, I said to doctor, I've been sitting here and people are coming, delivering, and they are leaving, and this is a government hospital in Matatiele. I said, people are leaving. So they did their due diligence. I was taken for sauna because I want to go home, right? Doctor took me for sauna in the morning, and I was discharged at around 3:30. Got out, and I thought, you know what, because this baby is now coming, and in our culture, we don't pile up baby stuff because you don't know if the baby is going to live, and then you will still be stuck with that. So I got out in town, bought little stuff, got home. On my way home, I started feeling pain. Got home a bit late-ish, around 18 hours. All my family had traveled, so I was with my in-laws. And that night, I lost my baby. I lost consciousness. I was driven, and this is gravel road, so it's not like zoop, you get there. I can hear everyone. I cannot tell them anything. I can hear them talking around me, but when I got there, coming to the limited resources, I remember I can hear, but I can't see. When I got there, I know that there was one registered nurse and a cleaner that were attending me.
A cleaner?
Yes.
Oh.
That girl ran the whole night. That registered nurse ran the whole freaking night. And if she hears me and she still remembers the story, the lady phoned everyone. Remember, now I can hear. My level of consciousness is not up to the good levels, like I can hear and respond, no. But all I could hear was, can the doctor just get here? Now my question was, this lady has attended me the whole night. What happened to the other ladies that were giving birth? And at 4, they were arranging an ambulance. Now my daddy is dead in the stomach. Sorry, I'm going to use that word. My baby died in the stomach, and I could hear them. They're struggling with the drip. Doctor says, cut down. Everyone is running. It's the sister and the cleaner. What happened to the other ladies that were delivering that night or that came in that night? At 4, she was arranging to transfer me to Mthatha because I needed a lot of blood and and she had 2 pints, 1-2. And I had finished it for that met. So now as she's arranging for the ambulance, a matron comes in at that time. She's shouting because they never wrote anything on my records. How do you expect this one nurse to write and be accurate in her record keeping, save my life, and arrange everything else that needs to happen when the doctor joined her 2 hours later? You see? So there are things that really are beyond the nurse's control. But there are circumstances that people need to prioritize. You see, I was a patient, but I'm just wondering what happened to the rest of the patients that night. And when I was discharged from Mthatha, I went back to the hospital. I wanted to see that matron. And then I was just a human being. I said to her, I appreciate the efforts that the nurse did, and I know where you're coming from. But did you really think about the fact that she was alone as a skilled person who's supposed to do the right thing? Because cleaner was just running for her. But that cleaner knew everything that a nurse is supposed to know because obviously they did the right thing. I'm here today talking to you. So the resource allocation plays a major role, which then leads to compassion fatigue. That is why nurses are rude. They are tired. Compassion is gone. Compassion fatigue. is real. They cannot take care of themselves. They cannot take. Remember when they from the hospitals after taking care of 50 patients, they need to be go home and be mothers. They need to be themselves. Amanas are one alive. They sleep. Amanas, they sleep. They are tired. Those people are tired. They are tired. So compassion fatigue is real. That is why in this generation you see us walking out of the profession. The brain drain is really now it. Either people are saying, "Aguna nemali lana," and I'm frustrated, they go abroad, or you know what, let me start my private practice and just get a break because it's getting too much.
So is there anything else that maybe that you know that when you get that compassion fatigue that you actually do so that you can come back and be the best version or the best nurse in the hospital? Or is it a matter of when you get there, you leave?
When you get there, the problem is the inability to take leave frequently as you would want to. Because we also need to share the time and the days. I cannot now be saying I'm taking 30 days when none of us in this shift have taken, you see. So the availability of leave, the compassion amongst management as well to say, you know what, I am aware that you haven't been on leave for 3 months and I can see you are not this person that I used to be. Allow you to take a few days. And what I used to do, Mina, because our shifts, there is a long week and there's a short week. So a long week is when you work Monday, Tuesday, you are off Wednesday, Thursday, and then you work Friday, Saturday, Sunday. Your short week is you work Wednesday, Thursday. Then I would say take the 2 days. To me, it's like uhambis katisnan, but actually you're taking a full 7 days, which then helps you to recoup and be at home and do whatever you needed to do.
So now let's go into the NHI Bill. What is the NHI Bill and what is its purpose?
The National Health Insurance Bill is aimed at opening access to healthcare for everyone. The services that is better, the service that is not paid for, which means then the government is trying to improve its efficiency and is trying to say we can provide a good service without you guys paying for it. It will be a funded system, that hence insurance, you see, hence insurance. But it's going to be government driven.
So
simple.
Who's funding it exactly? Oh, us.
It's us.
Taxpayers.
Yes. Obviously, government
so
has
after I fund it, after I fund it, do I now cancel my medical aid?
At this point, there was still a debate. You see, they're still taking each other to court, and the other one is saying it's not going to work. The other one is not saying. So private healthcare says, we are happy to support the health insurance, but let us collaborate and let us make it work together. Because now the perception, which I am not sure how is it going to be resolved, is that private healthcare is not going to be there. No, private healthcare will be there, but there will be a way of servicing. There will be a way of charging. So you will still pay your medical aid, but it will be out of your own will. Another hoo-ha that was now trending was that fact that the savings, the tax rebates that we were getting from our medical aids will be used for that funding. You can see that tax is everywhere. Not interested. It's SARS this, SARS that. So those are the ways there are ways that government is aiming at NHI.
Okay. So do you think this is going to solve the problems that are within the healthcare system?
Yes and no. I, for one, as a person who is employed, don't want to pay medical aid because that is a lot that it takes in my pocket. That is my net income that should be staying. I have a basic right that I should be serviced for free in healthcare, that I choose to go private because in the free service, I don't get served. Right? That is the only reason we pay medical aid, or maybe you have a different view.
100%.
That is the only reason we pay medical aid, is that the government facilities are not efficient as we want, according to our perception. Bona they are, in their view, and their broad spectrum, They are very efficient. But according to us as the customers of their service, they are not. Because like you were saying now, you go to the hospital, nurse is there standing, when memezala, abe TB ngala, abe HIV ngala, where's confidentiality? But because this nurse is trying to be directing and then it clouds the whole ethical side of things. You know, the values, now they are not there because privacy is gone. But otherwise, if NHI preparation, and I wanted to talk to NHI and customer service, and that is where I said to you, we'll talk about it here. If you want to bring NHI and you want us to trust you, be vocal about the customer service government. Be vocal about the resource allocation. And I'm not talking now about nurses and doctors that are not there. Nurses and doctors are not there. But medicines are not there either. Aguna Panado e clinic. Aguna oxygen. Most of the government nurses now and the doctors on TikTok are creating awareness on please arrive alive, drive safely on the road. It's festivities now. Make sure that you are safe on the roads because, guys, we have no resources. But it's people working in there. So they are there to serve, but they don't have equipments and other stuff to serve the communities. Theater time is not there.
That's very interesting, hey?
Yeah.
That's a lot.
NHI trying to improve efficiency, spot on. As long as we start by making sure our facility is ready for the NHI. When last were you in Para? Maybe you need to pay a visit in Para. The buildings are dilapidating there. They are dilapidating there. Everywhere you go, it's queues. So how are we going to say we are efficient? We haven't started it. We haven't started seeing that progress. So we are seeing a lot of work in the administrative space, but in operations we are not seeing a movement. As soon as we start seeing a movement in operation, the facilities being clean, I get there, I get served. I don't wake up at 5 to stand in the queue and be served at 4 or not be served at all. Then we are going to say, it's coming to work.
Yeah. Because also, I mean, you're saying there's nothing that's necessarily like happening, but we've seen people take the law into their own hands. Like Operation Dudula, for example, you know, making sure that illegal immigrants do not have access to public health care. So, what do you think of that?
I am not much invested in what Operation Dudula does, because going out to chasing foreign nationals from accessing a basic right as trying to do something good, I don't see that being something good, because according to our constitution, everybody has a right to basic healthcare, to basic needs, and healthcare is one of the basic needs. They are one of our basic rights as citizens. And according to the National Health Act, there is no way where it says we must discriminate against everyone who comes as in need of services. They should be rendered a service. And in private healthcare, we will allow you in because you are going to pay for the service and no issues. We service you, you go, we're not interested whether you are brown or orange. However, when it gets to government and they are saying that overcrowding is an issue, I don't think overcrowding is an issue because we have foreign nationals. Even in the village where there are not many foreign nationals, the queues are long. There are no medicines. So aqedoba nemakhaya because agekho ke uforeigner ngale. You see, so Operation Dudula should be engaging in the administrative roles and trying to do root cause analysis. It may be part of it, but it's not entirely the issue that we have foreign nationals that are accessing our services. No, it's not.
Because they are busy. Like there was even an article and a video where Action SA was blocking foreign nationals from accessing Hillbrow Clinic.
Yes.
And they were saying over 80% of the patients are illegal foreign nationals in that clinic. So they were blocking them that if you don't come with your ID or a passport or some form of documentation that you are legal in SA, you will not get healthcare. Which now my
Remember,
yes,
the reason you will find 80% there and the other 10% are those people that are able to pay you, Sister Khululwa. Because instead of me going there to wait, I will pay a consultation fee with Sister Khululwa, and Sister Khululwa will give me a script or will treat me and do whatever, put up a drip with her doctor and whatnot. But the people that have no means, they are forced to wait. Yeah, but so the foreign nationals then will wait. They will wait now, but they have an option of going to paying, and they do. They go and pay. Those people pay the biggest bills in private healthcare because they want their treatment. Yeah, but a foreign national will get into private healthcare and pay 200,000 now, and they go in the afternoon and bring another one, and they come there because they need the service. So it's a need, guys. Akekho umuntu who will wake up in the morning, ayesibhedlela and just net for control. It's not.
So now what happens if a foreign national is pregnant and they give birth in the public or in the private hospitals? Like, because is there like a home affairs service there where you register the child like we do in the public hospital, the same as the private hospital? So what happens in that case?
We do facilitate birth registrations, but remember, we don't force you. When you come to us and you deliver your baby and you see, you carry on with your life. Tina, all we needed to do was to make sure you are healthy and you are safe with your baby, and that's it. Documentation becomes another thing, but we will give you the documents that are required. However, if you look at how the service should be, when you are delivering a baby, you are delivering a baby and then it's registered there and then. So register ngani. Because unomfundo suddenly wakamtshali, but you have got nothing mtshali related with you. And that is when then they start panicking, because we look for these documents, they go and copy any other document on the street that they find. But we do pick them up, because the moment we start interviewing you and we realize with is not make sure here. So those are then we ask, private gumnand. It's not my business, it's not my monkey, not my circus. All I need to do is to make sure you are healthy and safe, and that is my legal aspect. Now, there is no one who's supposed to be turned away by a healthcare professional. That is why Operation Tutula and them and everyone else who has strong feelings around this, they feel the need to go there and chase people out. As a healthcare professional, if an accident happens here, ambulance gets here, and I am a polytrauma patient, who means I am critical. If the airlifting happens here, helicopter stands here, it doesn't ask who to the medical aid, because the nearest hospital is Life 4 Ways, right? So they need to take you to Life 4 Ways, be stabilized there, and then now decide to go according to your documentation. Are they transferring you to Bara or whichever other academic hospital that will be able to handle your case? But by right, whether you have got medical aid or not, the triage system is there. Now, people, please don't go and influx private hospitals just because I've said this on air. You will still wait, because we will do a triage. A triage system is there to determine your level of agency. So if you are deciding, I'm going to go to private hospital because in Petro is usazohlala ebenchini nase private hospital, because nase private hospital akhona ama waiting times. By the way, the issues that we have at government are there at private healthcare, but we address them quicker. And remember, the people in private healthcare are people with options. So if your other private healthcare fails to address your issues, we have a teacher and you're like, I'm going to leave you. I'm now going to seek health care there. So that is why they are seriously taking the patient experience very high, because reputation and revenue for them.
Reputation and revenue.
Yes.
I like the last part.
Guys, we cannot run away from the fact that private healthcare is there to make money. It's a business. In as much as I used to tell my nurses, unfortunately, you're selling healthcare. So you better act like a salesperson. Yes. Upsell. Act like a salesperson. Upsell. Sell your personality, sell your brand. That is why I look like this. You sell your brand, you sell your personality, you sell everything. Make the patients fall in love with you. Kuba ne patient nje ethi maruyema ofini. Yo. Maubuya, patients be bright. How are you back? Because you are serving them the right way. And unfortunately, that is just what government needs to do for their NHI to be successful. Or else, usazos taxa, and we are still going to pay our medical aid. And because that is another problem with us as South African citizens. Wherever we can buy, we opt to buy instead of fixing.
100%. So now I have a question. What happens if an illegal immigrant dies after they've been airlifted to a hospital, a private hospital, before anything else could happen? What happens to that person or to that body in that case?
No identification.
Yes, they're not South African. There's no identification.
We involve the police.
Okay.
Yeah. Then it becomes a police case. Police comes, they take the statement, they take the body to the government mortuary. As compared to a normal death of a South African citizen, where if it's a traumatic event or it's an unnatural death, there are two deaths, natural and unnatural. So unnatural death will always take you to the forensics, which we involve the police, and then they come take statements, they take the documentation, and then you are taken to the government forensic mortuary. And then from there, you can be taken by your family to be buried after the postmortem and the likes. In natural death, ushonile sibizo afbopo, and it ends there.
Why are you calling afbop if you don't know who I am?
That's why ngisho ukuthi, so if you are a foreign national and you don't have identification, police.
Police, okay.
Yes.
Doesn't matter whether you're natural or natural.
Police. If your family yakho ayikho, awunamaphepha, police. If your family yakho iyeza ithi I know sizomthatha sicela death certificate uyahamba. For a natural death. Unnatural death, always police.
So, is it true or false that if a child is born from an illegal immigrant, that they are not a South African citizen?
They are not.
Yes. If someone is born from an illegal immigrant, that child, are they a South African or is not a South African citizen?
What makes you a citizen?
Because I was born in the country.
So the child is born in the country. The child is a citizen. But the problem is the registration process, which is a home affairs process I cannot talk to.
Okay.
Yes. But if birthright is what makes you a specific nationality, then that child is born in South Africa.
Okay. Do you have any, before we close, can you tell the audience a bit about your business, how they can get a hold of you? There is a lot to actually cover, but the time has run away from us.
Yes, no, we can set up another slot. Thank you for having me. Once again, I run a home care business. We provide oncology and palliation, collection of blood samples, management of medication, patient assessment. It's a lot of services, but you can get hold of me, especially for those patients that are having cancer and they're struggling with their symptoms. You can send me a WhatsApp on 072-701-7302. That is my business number. You can reach me there for the service. Also, we have a wellness clinic that does the drips, intravenous therapy. So intravenous therapies are twice. There is medical intravenous therapy and there are those beauty ones. So the wellness clinic, mine is combined for wellness because I run it under, in a doctor's practice. So you are allowed to get in there and say you need a drip, and then a doctor will see you, and then we can give you medication for that drip that you require. For beauty drips, we also provide. We are based in Thokoza at Dr. Mota. It's Khumalo Street, next to Auto Parts General. If you come from Engine Garage towards ShopRite in Thokoza, Khumalo Street, Dr. Mota. If you go on Google, it says Mota, and then it'll show you Mota and Mufugeng. That is the right place. So if you want to book an appointment, you're welcome to send me a WhatsApp, 072-701-7302. Thank you very much.
100%. Thank you so much for joining us. I mean, that was insightful, very educational. You know, I'm definitely going to book another session because I'm very curious about what's happening within the healthcare center or the healthcare industry to say. So please, guys, don't forget to like and subscribe on our YouTube channel, and don't forget to follow us on social media at Set Podcast. I am your host, DJ Matlala, and we will see you next time.